Good morning, everyone. This is Dr. Sivaji Patibandla, cardiology resident in Maharishi Markandeeshwara University, uh, Ambala, Haryana. Today, I am going to present one interesting case which has been admitted in our cardiology department. The patient has it is a total IVC obstruction with collaterals in a young patient with under background of Crohn's disease. So, introduction: inferior vena cava thrombosis as is an entity which is given less importance, that is associated with significant morbidity and mortality. About 2.6 to 4% of patients will have DVT. The incidence of unprovoked DVT in young patients is rare, that is especially below 30 years of age. Even total occlusion IVC can remain silent or else can present with the acute symptoms. The hypercoagulability states, which is related to neoplastic or hematologic abnormalities, and venous stasis, which is secondary to external pressure from tumors or any other inflammatory processes, and vessel injury due to trauma have all been implicated as primary mechanisms in pathophysiology of IVC thrombosis. Endovascular interventions play a major role in treatment of venous obstructive diseases. Endovascular interventions like catheter and also catheter-directed thrombolysis has been a pivotal adjunctive therapy in the management of both acute and chronic thromboembolic venous diseases. This therapy is most successful in acute thrombus, which is less than 14 days, and is less effective in chronic clot, that is more than 4 weeks. Percutaneous mechanical thrombectomy has been evolved in treating complex veno-occlusive diseases. These devices work by simple thrombus aspiration by Venturi effect. Endovascular therapy offers less morbidity and mortality when compared to surgery. Coming to the case history, this is 22 years young male presented with complaints of bilateral lower limb pain associated with swelling of limbs for 15 days, and he has developed shortness of breath for 15 days, and because of Crohn's disease, he is having anorexia, decreased appetite, and nausea for 15 days. And he was already on steroid therapy because of Crohn's disease. There is no history of trauma, surgery, long distance travel, or prolonged immobilization. On examination, BPU is 120 by 70, and a heart rate of 126. Bilateral low limb swelling was there symmetrically with pitting pit edema. The cardiorespiratory system and abdominal cardiorespiratory system was unaffectable, and abdomen was soft. All routine investigations, which includes hematological, coagulation profile, biochemical, were normal. ECG suggests of sinus tachycardia. 2D echo was done, which showed RA and RV dilated, moderate TR, and moderate to severe PAH. Ultrasound Doppler bilateral lower limb showed DVT, and which is extending up to infrahepatic IVC. In view of suspicion of pulmonary embolism, CT pulmonary angiography was done, and it showed pulmonary thromboembolism. IVC venogram was done to right femoral vein, which dominated total occlusion of IVC. We can see it here. There is IVC, from here is total occlusion, and this is filled by with collaterals. Then we have passed the wire, and the minimum flow is attained here, and then we have kept IVC filter to prevent further embolization with the help of guide wire, and balloon angioplasty was also done here. The patient was started an anticoagulation with intravenous injection heparin along with oral anticoagulants. You can see it here. The stent was placed here, and then post dilatation of the stent was done here with IVC filter here. This is the final result. It is known fact that Witkow's discussion. It is known fact that Witkow's triad, that is stasis, endothelial injury, and hypercoagulability, are the most common pathophysiology for predisposing to DVT. But unprovoked DVT, especially in young patients, needs thorough workup. Recent advances in utilization of ultrasound, CT, as well as endovascular procedures have resulted in an increase in detection rates of IVC thrombosis. About 20% of the patients with the diagnosis of IVC thrombus may present with pulmonary embolism. So CT pulmonary angiogram is needed to evaluate pulmonary embolism. The treatment options in case of IVC thrombosis without anatomical variance include anticoagulation, mechanical thrombectomy, systemic thrombolytic therapy, transcatheter regional thrombolysis, and angioplasty. There is no specific literature describing the ideal duration of anticoagulation in these diseases. However, case evidence identifies a trend toward the treatment of minimum of 1 year and maintaining the target INR 2 to 3. Endovascular stent placement in combination with angioplasty is recommended in the case of residual stenosis with chronic IVC occlusion. The learning points: deep vein thrombosis of inferior vena cava, iliac veins, and femoral veins in young adults is rare, but it is associated with high significant morbidity. Understanding the embryological IVC development and pathophysiology of thrombus formation is critical to suspect congenital anomalies of IVC, especially with bilateral DVT. The initial diagnostic procedure should be an ultrasound of the lower extremities. Further investigation modalities are mandatory with the detection of iliofemoral thrombosis. CT or MRI is required to identify the extension of thrombus and IVC anatomy. For complete evaluation, thrombophilia workup should be performed. A treatment option includes anticoagulation, thrombolytic therapy, mechanical thrombectomy. In case of IVC development abnormalities, the location and type of the defect determines surgical approach. Even with extensive therapeutic modalities, long-term or even long life anticoagulation is often required. The patient has been followed up every monthly here, and he is doing well now here. Thank you for giving me the opportunity.